Welcome to Emergency Insights. I'm James Carter. Today we're looking at a critical and often missed diagnosis in the emergency department, the spinal epidural abscess. Epidural abscess is a rare but devastating condition, often masked by non-specific symptoms. With me is Dr. Lillian Wu, a leading expert in acute care medicine. Dr. Wu, thank you for joining us.
Thank you, James. It's a pleasure to be here. This is a topic I feel passionate about because of the huge impact a misdiagnosis can have on a patient's life.
Let's start with the basics. Why is a spinal epidural abscess considered one of the most serious conditions to miss in a patient with back pain?
The simple answer is the potential for irreversible harm. While most back pain is benign, an untreated spinal epidural abscess can rapidly progress from a subtle infection to causing permanent neurological damage, including paralysis or even death. The insidious presentation means it's often misdiagnosed as simple musculoskeletal pain, and that delay is precisely what leads to catastrophic outcomes.
The data you've mentioned before is quite alarming. Almost half of these patients are initially misdiagnosed and visit the ED multiple times before a correct diagnosis is made. What makes the clinical presentation so challenging?
The primary challenge is that the classic triad of spinal pain, fever, and neurological deficits is present in only a small minority of patients, just 10 to 15%. Many patients present with vague symptoms like general fatigue or diffuse back pain. Fever, which we often rely on as a sign of infection, is absent in over 2/3 of patients on initial presentation. The neurological exam can also be normal at first, which can be very misleading.
So, if the classic triad isn't reliable, what clinical findings should raise our suspicion?
The most consistent and crucial finding is severe focal spinal tenderness, disproportionate to what you'd expect from a minor strain. While patients may have diffuse back pain, a very specific and intense point of tenderness should be a major red flag. We also have to be hypervigilant about the presence of any risk factors, like a history of IV drug use, diabetes, being immunocompromised, or recent infection elsewhere in the body.
Speaking of risk factors, can you elaborate on which ones are most important for us to ask about?
Absolutely. We need to specifically ask about a history of IV drug use, which significantly increases the risk due to bacteremia. Diabetes and other immunosuppressive conditions compromise the immune system, making them more susceptible to infections. Recent skin infections, pneumonia, or even dental abscesses can be a source of the bacteria. And we shouldn't forget recent spinal procedures or surgeries, as these can also introduce infection.
Once we have a high index of suspicion, what's the next step? What diagnostic tools should we be reaching for?
When suspicion is high, the immediate next step is an MRI of the spine with gadolinium contrast. This is the gold standard diagnostic tool with a sensitivity of over 90%. It can visualize the abscess and determine its extent. We should not delay this key imaging, and we should never rely on less sensitive tests like plain radiographs or CT scans, as these can miss the diagnosis and only lead to dangerous delays.
And what about lab work? How useful are things like ESR and CRP?
Lab tests are supportive, but not definitive. An elevated ESR and CRP can support your suspicion of an inflammatory process, and these are often markedly elevated in spinal epidural abscess. However, they are non-specific and can be normal in early stages, so a normal result should never be used to rule out the diagnosis.
What would you say are the most common pitfalls that lead to a missed or delayed diagnosis?
One of the biggest pitfalls is over-relying on the absence of fever or neurological deficits. Another is being reassured by a patient's symptoms temporarily improving with rest, which can happen and often misleads clinicians into thinking it's just a strain. We also need to get better at recognizing and asking about risk factors and a preceding infection. Finally, and perhaps most critically, a failure to perform timely MRI due to low suspicion or limited resources is a major pitfall that can have devastating consequences.
Dr. Wu, this has been incredibly insightful. For our listeners, what's the single most important take-home message you'd like to leave them with?
The key message is to maintain a high index of suspicion for any patient with back pain who has a concerning history or risk factors. Don't be fooled by a normal neurological exam or the absence of fever. When in doubt, perform a thorough physical exam, look for that specific focal spinal tenderness, and advocate for an urgent MRI. Early diagnosis is the only way to prevent a benign-looking complaint from becoming a life-altering disability.
Dr. Lillian Wu, thank you so much for your time and expertise. This information is vital for everyone working in acute care.
My pleasure, James. Thank you for having me.
That's all the time we have for today. We hope this episode of Emergency Insights helps you in your practice. Join us next time for another critical topic. Stay safe out there.